it's very nice to see you and to see professors from India and Sri Lanka and our international friends. I mean, focusing on non-invasive technology in chronic liver disease, because as you all know, HK Medical is a young and very novel company in China, and their machine, the FibroTouch one, is very simple and useful, applicable. I have two machines in my unit, and it's very useful for. It's very friendly for the operators, for nurses, and so it's will provide more and more data about in the liver international in the liver disease. So and also I'm honored to introduce the first speaker, Professor Arjuna de Silva, and his topic is about the application of the TE in management of chronic liver disease. And so the questions and answers will following the topic. The speaker is Professor Madan from India, and yes, very famous hepatologist and president of the Indian National Association of Study of Liver. And Professor Madan's topic is about the liver stiffness management in patients' management of ACLD. Yes, please.
Right. Thank you so much, Professor Chen, for the introduction, and thanks to Dr. De Silva for making my job easier by the initial introduction. And thanks once again to Lee from High Sky for holding this meeting. So I've been asked to speak on role of liver fibrosis measurement by transient elastography in cirrhosis. So why so much fuss about measuring fibrosis in patients with liver diseases? So I think there's a total change in paradigm now with the understanding that it is the fibrosis which is the main driver of the disease. And just to highlight, I'll just share with you these 3 studies in NAFLD patients. So this was the initial studies between 1975 and 2005. 619 biopsy proven NAFLD patients were followed for a median of 12.6 years. 193 had outcomes in the form of death or undergoing liver transplantation. And look at this, the risk of death and liver transplantation were directly correlated with the stage of the disease, and there was a dose-response relationship. As the stage went up, as the stage of the disease was higher, the fibrosis stage was higher, so was the risk of developing these outcomes. And when they looked at whether the patient had NASH and fibrosis, so these 2 lines, the green and red one, suggested that patients either had no NASH but fibrosis or NASH with fibrosis versus those who did not have fibrosis. The overall survival was significantly lower in patients who had advanced fibrosis versus those who did not have fibrosis, even if they had histological NASH. So fibrosis was more important than NASH. Another study, 229 biopsy proven NAFLD followed for a mean of 26.4 years. So many of them had biopsy proven NASH, but no fibrosis. And the other group had stage 3 or 4 fibrosis. So it was this group which was associated with hazard ratio of 3.3 for liver related outcomes and not the presence of histological NASH. Subsequently, another recent study, 209 biopsy proven NAFLD followed for a median of 150 months. They gave a new concept of steatofibrosis. 97 patients had steatofibrosis, that is at least 5% steatosis and more than 1 stage fibrosis. That means F2 and beyond. So those who had steatofibrosis, their survival over long term was significantly lower than those who did not have steatofibrosis. But when they compared NASH versus no NASH, there was no difference. Meaning thereby that fibrosis is now identified as the new driver of progression of liver disease. So the importance of measuring fibrosis at baseline and repeatedly, something which can only be possible with a non-invasive tool, because it's very difficult to do repeated biopsies in the patient. Even doing a one baseline biopsy in many of these patients becomes very, very difficult, and forget about repeating biopsies in these patients. So fibrosis, if it can be measured non-invasively, is possibly the best way of prognosticating these patients. So where is the role of TE in cirrhosis? One, in making a diagnosis of cirrhosis, and I think Dr. Arjuna made it very clear regarding how TE makes the diagnosis of F4 and beyond fibrosis easy. So in various etiologies of liver disease, these are two large studies in hepatitis C. As you can see, in F2, F3 disease, it may not be that efficient, but when it comes to F4 disease, you can see the aurochs are above 0.95. So 95 and 0.97 if you have to make a diagnosis of cirrhosis in patients who have hepatitis C. Similarly, two large studies of hepatitis B, which looked at transient elastography cutoffs, again showing that in the F4 fibrosis group, although in F2, F3, there were discrepant results, but still upward of 0.80. But when it came to F4 or beyond fibrosis, the performance of TE was excellent in terms of making a positive diagnosis of F4 fibrosis or cirrhosis. And then the comparison in patients who have non-alcoholic fatty liver disease of various non-invasive tools of detecting fibrosis, the FIB4, the NAFLD fibrosis score, transient elastography, or MR elastography. Again, you can see that when it comes to diagnosing more than equal to F2 fibrosis, this was a study done in 142 Japanese patients. TE was inferior to magnetic resonant elastography. But when it came to advanced fibrosis beyond F3 or F4, TE was as good as MRE and much better than all other non-invasive means of making a diagnosis of F3 or F4 fibrosis in NASH patients. So we've seen that TE makes an excellent positive diagnosis of cirrhosis in these patients, provided you are well aware of all the caveats associated with measurement of TE. And Dr. De Silva had very elegantly told you about all those caveats which must be kept in mind when assessing these patients for fibrosis. The second important role is assessing portal hypertension and its follow-up. We all know that, classically speaking, this is how the portal pressure or hepatic venous pressure gradient is measured, which is an invasive tool. You put in a balloon catheter, balloon-tipped catheter through the femoral vein or through the SVC into the right hepatic vein. Then you inflate the balloon, take the wedge hepatic venous pressure, deflate the balloon, take the free hepatic venous pressure, and the difference is called HVPG. We all know that if it is less than 5, it is normal. When it is more than 10, it is called clinically significant portal hypertension. That is where the varices start forming. And the varices, high-risk varices, start bleeding when the portal hypertension, the portal pressure is even higher with HVPG of more than 12. So HVPG has been shown to be associated with clinical outcomes in cirrhotics. Among 393 cirrhotics, higher HVPG was associated with higher overall mortality, with 1 millimeter increase in HVPG associated with 3% increase in mortality in these cirrhotics. Another study, 90 non-critically ill cirrhotics, 22 died over 24 months. Those who had an HVPG of more than 7 had a lower survival as compared to those who had an HVPG of less than 17. So HVPG correlated with clinical outcomes. Further, HVPG also correlates with presence of high-risk varices on endoscopy. So these are large high-risk varices with red color signs seen on endoscopy in a cirrhotic patients. These are also called varices needing treatment or VNTs. So if you find this, you put these patients on primary prophylaxis either with EVL or beta blockers. So here comes the role of FibroScan, or transient elastography. So does liver stiffness correlate with HVPG? So look at this study, 61 HCV related cirrhotics, this side HVPG, this side liver stiffness. Very beautiful correlation, linear correlation. As the HVPG increases, so does the liver stiffness increase in these patients. And they even gave certain cutoffs. So an HVPG of more than 10, also called clinically significant portal hypertension, could be diagnosed at a cutoff of 13.6 kilopascal, and higher portal hypertension, that is the high risk portal hypertension where the varices bleed, could be diagnosed at a cutoff of 17.6 kilopascal. But these were small number of patients. So that gave us the concept of CACLD, or compensated advanced chronic liver disease, by Baveno, and Dr. De Silva did talk about that. This is usually detected incidentally. Believe you me, there was time when we were not able to diagnose this group of patients. These patients were mostly diagnosed when either they would undergo autopsy for some other problem, and you would find cirrhotic in these patients. And now we have a tool to detect these patients, detected incidentally in CTP-A stage by means of non-invasive means like transient elastography or fibro test or MRE. So what do you need to do in these patients? I told you that there might be some overlap between my talk and Dr. De Silva, and he did touch about these, the high-risk varices or the varices needing treatment. So this was the initial criteria which was given by Baveno 6, which said that if you had an LSM of more than 20, liver stiffness measurement of more than 20 kilopascal, and platelet count which were less than 1.5 lakh, these were the group which were highly likely to harbor VNTs or varices needing treatment, and therefore you do endoscopy only in these patients. So if LSM was less than 20 and platelet more than 1.5, you could rule out VNTs and avoid doing endoscopies. And this was further confirmed with this meta-analysis of 15 studies that the negative predictive value of this cutoff was 98%. So this was excellent for ruling out varices needing treatment or VNTs. Another study which highlighted this, but the number of spared endoscopies during this using this criteria were only 20%. So there was a need to have a balance where you could increase the number of avoided endoscopies without missing VNTs to make the non-invasive criteria practically more effective. So then came this study by Augustin, 499 patients, varices needing treatment were present in 14%, and then they tested all these cutoffs and came to this conclusion that if your platelets were more than 110 and LSM was less than 25 kilopascals, then you could spare 32 endoscopies and miss only 1.9 VNTs. So this was the criteria which has been picked up by Baveno 7, suggesting that in these patients you can avoid doing endoscopies and still miss only a few varices needing treatment. And this was further validated in 3 different cohorts of almost 1,000 patients, and 40% endoscopies could be spared with missed VNTs of only 1.6%. Now, please remember that portal hypertension has 2 components, the static component and the dynamic component. Static component is driven by liver fibrosis and architectural distortion in the liver. Dynamic component is driven by intrahepatic vasoconstriction and splanchnic vasodilatation. And liver fibrosis measurement is only able to pick up static component. So if you see at higher levels of HVPG, the correlation between liver stiffness and HVPG decreases. Whereas if you had looked at the previous part of the graph, the correlation was much better as compared to higher HVPG. So what do you do for higher HVPG patients? You measure something related to spleen, like the spleen size or splenic stiffness. Splenomegaly, as you know, is a common finding in patients with cirrhosis and portal hypertension because of a number of reasons as mentioned here. So these investigators came out with the concept of platelet to splenic diameter ratio, and they used two cohorts, the derivation and the validation cohort, and divided the patient into groups which had esophageal varices or no esophageal varices. So as you can see, the patient with esophageal varices had a significantly lower platelet count to splenic diameter ratio, or what is called PSR, in patients with esophageal varices, whereas those with no esophageal varices had higher values, and this had a sensitivity with a cutoff of less than 909, a sensitivity of 100% and specificity of 71%. So then came this new parameter called LSPS, where liver stiffness was combined with the platelet splenic diameter ratio. And as you can see, the OROC of this particular parameter was significantly better than the liver stiffness alone, or splenic diameter alone, or platelet count alone. This was called LSPS, and a few authors gave cutoffs of LSPS as those who had LSPS of more than 6.5 were likely to have bleeding from esophageal varices, and those who had a cutoff of more than 9.5 were likely to have high-risk varices, which were likely to bleed. So these are also non-invasive tools which combines liver stiffness, platelet, as well as splenic diameter to categorize the risk of bleeding and risk of presence of high-risk varices. So that brings us to another tool called the splenic stiffness, another use of the transient elastography machine. The same FibroScan machine or FibroTouch machine can be used to measure splenic stiffness with a patient in the supine position, left arm fully abducted. You need an ultrasound localization of spleen over the left lower intercostal space. Your splenic depth there should be at least 4 centimeters. And then you measure the splenic stiffness in the same way as you measure the liver stiffness. The RFI machine also has been used for this purpose, and with almost similar results. So this was the study which initially looked at splenic stiffness. It compared splenic stiffness, liver stiffness, platelet spleen diameter ratio, and the LSPS, and found that the splenic stiffness correlated much better with the HVPG as compared to liver stiffness. You see, liver stiffness is going on both sides of the line, whereas splenic stiffness gives a fantastic linear correlation with HVPG as compared to splenic stiffness. And they also gave cutoffs. So if your splenic stiffness was less than 40, it rules out clinically significant portal hypertension. More than 52 rules in CSPH. Similarly, if it was less than 41, it ruled out severe portal hypertension, that is HVPG of 12. And if it was more than 55, ruled in severe portal hypertension. Now, this was another study which was done in this regard. This was from India. 52 of 174 cirrhotics who underwent HVPG. The splenic stiffness correlation with HVPG was higher as compared to just liver stiffness. They also compared this splenic stiffness with liver stiffness, LSPS, and PSR, and found that the OROC for splenic stiffness predicting the presence of esophageal varices was much better than all other parameters. Now, this is a very important application of measuring splenic stiffness. In order to find whether a beta blocker in patients with primary or secondary prophylaxis is working, you need to demonstrate that the HVPG comes down by at least 20%, or the HVPG comes down to below 12. That means repeated measurement of HVPG by an invasive technique. Putting in a catheter through the femoral vein into the hepatic vein is obviously painful and invasive, and patient wouldn't like to undergo that again and again. So can that be countered by using some non-invasive technique? So yes, this study looked at this. So non-invasively measuring changes in HVPG can theoretically also help in monitoring the efficacy of beta blockers as primary prophylaxis of bleed. In this study, 169 compensated cirrhotics with high-risk varices were given beta blockers. On HVPG monitoring, 53% were responders, 47% were non-responders based on HVPG. And look at this, those who were responders as per HVPG, their splenic stiffness, you can see, significantly came down as compared to those who were non-responders, whose splenic stiffness went up. So splenic stiffness can be used as a surrogate of to HVPG measurement for monitoring response to beta blockers. And finally, last few slides, predicting liver-related outcomes. So transient elastography now has a role in predicting liver-related outcomes, especially in those who have advanced fibrosis or CACLD. We all know that this is the Laennec classification of cirrhosis, where stage 4 is further divided into stage 4A, 4B, and 4C, based on the thickness of the septae and presence of shunts. So as you move from 4A to 4C, the cirrhosis becomes irreversible. So, and it has also been shown that this also correlates with the clinical outcomes. These were 175 CLD patients, median follow-up of 52 months. As the stage from 3 to 4A to 4B and 4C went up, so did the cumulative incidence rate of liver-related complications or liver-related events. So 4A, 4B, 4C is not just a figment of imagination of a pathologist, they are also associated with poor outcomes. So can a non-invasive means tell you whether the patient has 4A, 4B, or 4C? The answer is yes. This study showed that the liver stiffness value in 4A, 4B, and 4C was significantly different. From 4A, it rose to 4B, the stiffness rose to 4C. So even LSM, liver stiffness measurements, correlates with the Laennec stages of cirrhosis and therefore the clinical outcomes. I'll just talk about these two studies in HBV and HCV related cirrhosis. These were 34 patients of 381 CHP patients on antivirals who developed HCC after a median follow-up of 48 months. And as you can see, those who had a baseline LSM of more than 13 were the ones who were more likely to develop liver cancer as compared to those who had a baseline liver stiffness of less than 8. Similarly, HCV patients, this is years after enrollment, you can see there is a dose-response relationship in terms of development of liver cancer. As the LSM increases, so does the risk of development of liver cancer later on, and it is correlated with the presence of degree of liver stiffness. I'll just skip this and come to this final study, which is the recent study published in 2021. And this possibly silence all those critics who tell me, you already have a cirrhotic. Why do you need to do a fibroscan? Why do you need to do a transient elastography? You know this guy has cirrhosis. So this study answers their question. 1,000 NAFLD patients with CACLD who had F3, F4 fibrosis on biopsy or LSM, remember, or, so all of them did not have a biopsy, LSM of at least 10 kilopascals, followed up for a median of 35 months. The baseline LSM, if it was more than 21, it was associated with higher risk of liver decompensation. If it was less than 21, the liver decompensation risk was very low. Again, highlighting the fact, the cutoffs given by Baveno 6 earlier of LSM 20. So these are the patients of CACLD who have high LSM at baseline are likely to progress. So even if you have made a diagnosis of cirrhosis by an ultrasound, please do their LSM and you'll be able to risk stratify these patients. Another fantastic part of this particular study, they divided their patients on follow-up based on repeated LSM measurements. And they divided the patient into those who had an LSM reduction by at least 20%, worsening of LSM by at least 20%. Look at this. Those who had worsening of LSM on follow-up by at least 20% had higher risk of liver decompensation as compared to those who had improvement in LSM over follow-up. So repeated measurement of LSM using transient elastography also has a role in managing your patients of cirrhosis or CACLD. And not only that, this categorization of delta LSM, improvement in LSM or worsening of LSM, again had a dose response relationship in terms of liver related deaths. So if the LSM worsens, then the patient is more likely to die of liver related causes as compared to those who had an improvement. And this improvement you can follow if you are treating these patients. For example, Hep B cirrhosis, you are giving antivirals. NASH cirrhosis, you are making sure they reduce 10% of body weight. Hepatitis C, you are giving directly acting antivirals. Autoimmune hepatitis cirrhosis, you are giving steroids. So all these patients, you can show them that their LSM is improving. So is their risk of dying because of liver disease. So I'll end here and summarize that non-invasive measurement of liver fibrosis gives us a wealth of information and has shifted the paradigm from demonstration of inflammation on a painful invasive biopsy to a painless demonstration of more than equal to F2 fibrosis in a clinic. It seems to have a very high diagnostic value in detecting cirrhosis, sitting in a clinic in all kinds of etiologies of liver disease. Among CACLD patients, a good non-invasive predictor of varices needing treatment can reduce the number of unnecessary endoscopies. So the Baveno 6 criteria, splenic stiffness or LSPS can be used. Dr. De Silva talked about the Baveno 7 criteria also, which can be used to detect CSPH, presence of varices, presence of high-risk varices, and the risk of first bleed. And finally, if validated in large studies, the efficacy of beta blockers can be effectively monitored using these non-invasive parameters, especially splenic stiffness. Baseline LSM values, as well as a change in LSM values over time, can be used to prognosticate these patients in terms of their liver-related outcomes, including liver decompensation, liver cancer, and liver-related death. Thank you very much for a patient hearing.
Thank you very much, Professor Madan. A very excellent talk about the transient elastography in ACLD in cirrhosis patients, including how to diagnose cirrhosis and how to stratify the portal hypertension, and finally, to predict the liver-related clinical events. So a very interesting talk, and I understand that Professor Madan go further to present the application of TE in different clinical scenario from Professor Arjuna de Silva. And so before the audience raise their questions, my question is that as Professor Madan mentioned that the fibrosis is main driver of the NAFL progression, and so the cutoff value is F2, that is advanced fibrosis, and finally, Professor Madan talk about the Baveno 6 and Baveno 7. That means it's ACLD, that F3 or even F4. So in the clinical practice, so my question is that in the clinical practice, which cutoff value is more important, F2 or ACLD? Thanks.
Right. So I think that's a very important distinction which you have made. I think what I do in my clinical practice is if the patient has just F2, so somewhere around 8. So it could be 7.9 also, or 8.1 also, or 8.5 or 9. I usually tell them that this is the stage where you have to be really careful and everything is reversible. You can just lead a normal life. Whereas if it is F3 and F4, then the further monitoring changes. For example, the screening for HCC, these patients, if they have F4, they fall into the category of for HCC screening, and they have to be kept under follow-up. So a milder advice for those who have around F2, and a significant and stringent advice with or without pharmacotherapy in those who have F3, F4.
Yes. So to have a different cutoff is useful at our clinic. Yes, I agree. And I noticed that one audience raised the question about for both speakers. As both professors talk about the TE application in clinical practice, so how do you suggest to use TE to evaluate the complications of a NAFO patient? That the specific question is that what's the time interval for the follow-up with the TE? I mean, in FOD or in ACLD? Yes.
I'll just take, and then maybe Dr. De Silva can come in. So what I usually do is 3 months period, I think is too short for any changes to happen. So I usually advise them to undergo at least 6 monthly, and those who find it expensive, maybe once in a year, if they are a stable patient. So if they are, for example, in F2 or doubtful F3, then maybe 6 months to a year is what I would, the time interval between two readings. Dr. De Silva, you can.
Yeah, first I must congratulate Professor Kaushal on a fantastic lecture. I really enjoyed it. Yes, I agree with you. I think 6 months to 1 year is a good thing, and it depends on which patient and treatment as well. So I think definitely 6 to 1 year.
Yes. So maybe it depends on the specific conditions in your clinic, in your nation. So, and it also depends on the patient's condition, like the ACLD or even cirrhosis. We need to shorten the follow-up interval. Yes, I agree. And also it's my question is about the NAFLD, because the both speakers talk about the NAFLD, and the NAFLD is the most prevalent in our people, in our patients. So just like Professor Madan mentioned, the steatosis, okay, is just the indication of the fatty liver, and the NASH, I mean the steatohepatitis and the fibrosis. So which one is more important for patients and for clinicians? Because even the evidence shows that the fibrosis is determination of the clinical outcomes, but maybe all patients may care more about their ALT levels, you know. So yes, what's your comments from both professors? Yes.
Yeah, I mean, guys, when you talk about ALT, patients are worried about that, but there is absolutely no correlation, especially in NAFL, between elevated ALT and fibrosis. So there's so many studies showing that. So again, I think the main and cap for methylene fat, we need a lot more data before we comment on that. And still, there is PK18 biomarker for NASH, but we still have to go. If you really want to diagnose NASH, then you need to biopsy still. So I think, as we discussed, there's so much evidence for fibrosis. So I think transient elastography correlates very well with that. So we should still go after fibrosis as the main thing at the moment if you take the current evidence.
So I think I agree that ALT is an important surrogate marker, at least for in the clinics, to satisfy the patient's curiosity, because he came to you for a raised ALT, and if the ALT doesn't come down, he becomes discouraged. So that is one. Second, now with the advent of transient elastography, which we can do repeatedly, if there is an improvement, you can show that also as an improvement in his liver disease status. But what happens is, so this is also one of the reasons why I don't repeat it every 3 months, because if in 3 months there is no change or just a slight fluctuation, patient feels nothing has happened. So it's best to make sure that patient has reduced significant weight and you do it after 6 months. So yes, ALT improvement is a good surrogate marker and should be aimed for.
Yes. Okay. Yes. Then the patients and the kids will be satisfied. Yes. And okay. The following question is that do both professors notice that for the obese patients, if the body weight decreased sharply and the liver stiffness measurement, the values also decreased accordingly. So that really means the liver fibrosis, how to say, the attenuated or reversed?
I think one of the absolute transient elastography reading, the LSM value, may in these patients also reflect some inflammation which might be going on in the liver. So the initial improvement may also be related to inflammation, which is coming down. So this was, I think, classically seen in the era of DAA use in hepatitis C. So you remember many of these patients, the LSM would be high. You start them on directly acting antivirals, their LFT, AST, ALT becomes normal, some values which they had never seen in their lives. And you do a fibroscan measurement after a month and you see that there is a significant decline. You were labeling these patients as cirrhotics or CACLD a month back, and 2 months down the line, the LSM is normal or in the F2 range. And that made you realize that possibly the inflammation in the liver also drives the LSM values. And yes, there is some data also to suggest that, especially in obese patients who have very high CAP or UAP values, there might be some overestimation of, mild overestimation of LSM values due to high CAP.
Yeah, definitely agree with that. And the other issue is by doing fibrosis or fasting elastography, you have to use these patients BMI 30 or 28. We use a large probe, Excel probe, because that correlates better with the value. Then the other thing is, yes, definitely the information does correlate. And it's amazing how 10% weight loss, which is proven to reverse fibrosis, you can actually show that to the patient when he has a repeated transient done. So that, as Professor Kaushal mentioned, that is very satisfying the patient. One patient point of view, and it's evidence-based, we know that 10% weight loss can reverse fibrosis in nothing.
Yes. Yes, I agree. Maybe at this scenario is the inflammation maybe more important than the fibrosis. Yes. Okay. And I'm sorry, all the question all from me. And my final question is that, is it possible for hepatologists to build or to establish same criteria for FibroScan and the FibroTouch to rule in ACLD or to rule out advanced fibrosis? Because we have 2 machines, or even in the future 3 or 4 platforms. So for we are the customers. We need a very simple criteria for the different platforms. So it's an open question. Yes.
See, I've had the privilege of using both the machines extensively in my clinical practice, and my personal observation was that this particular machine, the FibroTouch, the one from High Sky, it has the advantage of having a single probe even for obese patients. so you don't have to spend more on the Excel probe. And the other high-end machine which they have, the FT1000, also has an inbuilt ultrasound platform which can be used for splenic stiffness. But having said that, in terms of its comparison to FibroScan, it sometimes give a value which is 1.5 to 2 times, 1.5 to 2 points, not times. So slightly higher than the original FibroScan machine. So if you know that, I mean, if you are the, like you said, the customer, you are the user base, if the hepatologist himself is doing the FibroScan, he knows about the case, then he's able to know that what these values mean. But if you get it done from, say, somewhere else, from a third vendor, a technician is doing it, and the patient comes back with a report, then both, I would say both machines you can have wrong interpretations of readings from both the machines. It's very important. I usually call transient elastography as a hepatologist stethoscope. So it should be available in your OPD. You should be able to do it. Then the interpretation is correct. Either machine you may use. And I agree with you, we need to have cutoffs for both the machine.
And Professor Ajina?
Yes, I think that brought up a very valid point. So that the pathologist stethoscope, I think that's very, very important, that someone who can really interpret this and implement, treat, do everything, like the pathologist use the machine instead of third party, because then the problems will arise. But I'm sure, like with time, because transient elastography is here to stay, and it will become like the normal ultrasound in the future. So therefore, very soon I think cutoffs will come, universal cutoffs will be there, with more and more compared studies. So I think, but what's important is to make this more and more accessible to people, especially so that we can use this to the maximum. So definitely, that's the way to go forward. The person who uses it should understand the machine well and to be able to be comfortable with that and interpret it. That's the most important.
Yes, agree. And a question from our audience for Professor Madan, because Professor Madan talked about the spleen stiffness in prediction the portal hypertension, and the audience confusion is that maybe, you know, sometimes the spleen size is small and it's difficult to perform successful spleen stiffness measurement. So how about your experience about the spleen stiffness measurement in clinical practice, Professor Madan?
Yeah, so I think you have to have a machine which has an inbuilt ultrasound probe to be easily able to do it. Otherwise, you'll have to have two machines, one the FibroScan or FibroTouch machine and a small portable ultrasound to localize the spleen at the area where the depth is at least 4 centimeter. Otherwise, both the companies have versions which have built-in ultrasound probes. The one I talked about from High Sky is the FT1000. I don't know whether I'm correctly pronouncing the name. And the other one from FibroScan is 630, their 630 version, which has a inbuilt ultrasound probe, which helps you do the splenic stiffness also. So that's the best way of doing it. No, right now we are not doing it routinely in our clinical practice, but I'm sure in future, measurement of splenic stiffness after a patient has developed cirrhosis or CACLD is going to have many applications for these patients.
Yes. And also we have made the spleen stiffness from since 2019, because using the old version of the FibroScan, and sometimes the operator need some training, and the patients, the obese patients or ascitic patients, that will decrease the performance of the spleen stiffness measurement. And I know, and the FibroScan has a new machine for the dedicated spleen stiffness measurement. It's a new one, and I wish the FibroTouch will provide a new option for us. I understand that the FibroTouch one to measure the spleen stiffness is not, you know, the range, the values of the range is not so wide. So I agree with Professor Madan that in the future, the spleen stiffness measurement will be more important for clinicians to recognize, to manage the portal hypertension of our patients. Yes, I agree. So I will conclude this session. And first, I will thank the both excellent speakers and our audience, because you know the topic is very clinical useful for the hepatologist, because Professor Arjuna talked about the T in the NAFL patients. That means it's a wide spectrum of disease. And Professor Menda talked about the T in the cirrhosis in ACLD and the portal hypertension. So it's it's a full spectrum of our disease. And the second is that, you know, the transient elastography is a very easily and friendly tool for operators, for hepatologists, just like Professor Madan mentioned that the hepatologist perform the measurement and interpret the values and care the patients. So this simple machine will, provide us a very useful tool. And finally, we will thank Husky Medical. Like I mentioned, this young and novel company from China has invested much in the non-invasive technology for liver disease, and their product, the FibroTouch, all over the world, from the One Silk One Road area, the Asian Pacific areas, and we wish more data, more academic activity from Husky Medical itself, it sponsored the research studies. So, and finally, thanks our audience and our speakers, our sponsors. We wish to see face-to-face in the future. Okay.
Thank you.
Okay.
Thank you very much.
Okay, see you.